Hello everyone and welcome back to my playlist of physiology. You are watching Dr. Asif lectures and my name is Professor Asif Qureshi. Today we are going to do chapter number 21 from unit 4, which is the cardiovascular physiology from Guyton. And the title of the chapter today is muscle blood flow and cardiac output during exercise, the coronary circulation and ischemic heart disease. So it's going to be a long chapter जिसमें basically हमने muscles के हवाले से बात करनी है कि muscle को blood supply किस तरह पहुंचती है. अब जब हम muscle की बात करेंगे तो obviously उसमें skeletal muscle भी है और उसमें cardiac muscle भी है. It's also a muscle. And we will also talk about what happens to the blood supply during exercise and then what happens during IHD, what we commonly call it as ischemic heart disease. Okay. So in this chapter we consider the following. Number 1, blood flow to the skeletal muscle, and number 2, coronary artery blood flow to the heart, because heart are also muscles na, तो उनको कैसे blood पहुंचते हैं, that's also important. Now regulation of each of these types of blood flow is achieved mainly by local control of the vascular resistance in response to the muscle tissue metabolic needs. That's a general principle. So for example, if this is a muscle bundle, skeletal muscle fiber, और ये exercise की situation में, so if the person is doing hectic heavy exercise, then the metabolic demand of the tissue increases and therefore there is vasodilation. And when there is vasodilation, there is more blood going towards the exercising muscle. इसे हम कहते हैं local control, and it all depends upon the metabolic needs of that particular muscle. We will also discuss the physiology related to the subject of cardiac output control during exercise and characteristic of heart attacks, which is what we call the ischemic heart disease, and the pain of angina. So if there is decreased blood supply, for example, to the always exercising heart muscle, because heart muscles are always and always contracting, so हर वक्त ही बेचारा बीट कर रहा होता है. जब से आप बल्कि पैदा होने से पहले से भी इन यूट्रो लाइफ में भी हार्ट कॉन्ट्रैक्ट कर रहा होता है. सो तब से लेके तो पूरी लाइफ जब तक खत्म नहीं हो जाती है, तो इतनी हैवी एक्सरसाइज तो और किसी मसल की बॉडी की है नहीं. तो अगर उसमें किसी भी वजह से उसकी कॉरोनरी ब्लड सप्लाई फॉर एनी रीजन ब्लॉक हो जाए या डिमिनिश हो जाए, सो समटाइम्स ये होता है कि योर हार्ट उसकी तरफ जो कॉर्नरी ब्लड वेसल आती है वो ऑल टुगेदर ब्लॉक नहीं होती, बट उसका ल्यूमेन छोटा पड़ जाता है. सो जो ब्लड गुजर रहा है उसका अमाउंट कम हो जाता है. सो यू स्टार्ट फीलिंग पेन. दैट पेन इज नोन एज एंजाइना पेक्टोरिस. उसके भी फिजियोलॉजिकल एस्पेक्ट्स हमने डिस्कस करने हैं. ओके, सो ब्लड फ्लो रेगुलेशन इन स्केलेटल मसल एट रेस्ट एंड देन ड्यूरिंग एक्सरसाइज. सो स्ट्रेनस एक्सरसाइज इज वन ऑफ द मोस्ट स्ट्रेसफुल कंडीशंस that normal circulatory system faces because there is such a large mass of skeletal muscle in the body. पूरी आपकी हड्डियों पर मसल ही मसल तो हैं, all of it requiring large amounts of blood flow. Also, the cardiac output often must increase to 4 to 5 times the normal in non-athlete to 6 to 7 times normal in well-trained athlete to satisfy the metabolic needs of the muscle. So when you start exercising, obviously your cardiac output, your heart has to work more. आपके दिल पे आप समझ लें कि काम बढ़ जाता है क्योंकि उसको तमाम मसल्स तक ब्लड पहुंचाना है. सो द कार्डियक आउटपुट हैज टू इंक्रीज दिस मच, 4 to 5, या अगर एथलीट है तो उससे भी ज्यादा. कितना ब्लड जाता है, व्हाट इज द फ्लो रेट ऑफ ब्लड टू द स्केलेटल मसल? रेस्टिंग कंडीशन में स्केलेटल मसल ब्लड फ्लो एवरेजेस 3 to 4 ml पर 100 ग्राम ऑफ द मसल. सो ये नंबर याद रहे तो ठीक है, नहीं भी याद रहे तो भी ठीक है. ड्यूरिंग एक्सट्रीम एक्सरसाइज द नंबर गोज 25 to 50 folds, increasing. इतना बड़ा नंबर कहाँ 3 to 4 ml per minute per 100 gram, कहाँ 100 to 200 ml per minute per 100 gram of the tissue. So that's a very heavy increase in blood supply to the muscle during exercise. Peak blood flow as high as 400 of muscle have been reported of the thigh muscles endurance, particularly जब वो हम बात करते हैं trained athletes की. Now blood flow during the muscle contraction, ये figure अभी हम देखते हैं. It shows a record of the blood flow changes in the calf muscle of leg during strong rhythmic muscular exercise. Note that the flow increases and decreases with each muscle contraction. At the end of the contraction, the blood flow remains high for a few seconds, but then return to the normal. So if you look at the diagram here, that is the rhythmic exercise. That's the resting condition, for example. So that's the amount of blood, 3 to 4 ml maybe. And then when the calf muscles start exercising, it shoots up, you see, and then it goes back down if the exercise is removed. So this is the time when there was exercise happening, and then this is the resting situation and resting situation. Okay, right. सो यहाँ आप थ्योरी बताइए कि ऐसा बेसिकली जो है ना हर कॉन्ट्रैक्शन के साथ देयर इज ऑब्वियसली नॉट अ सस्टेन्ड स्पाइक. आप देख रहे हैं ऊपर जा रहा है, नीचे आ रहा है, ऊपर जा रहा है, बिकॉज मसल कॉन्ट्रैक्ट होता है, रिलैक्स होता है. The cause of the lower flow during the muscle contraction phase of exercise is compression of the blood vessel, obviously of the contracted muscle. So muscle जब ज़्यादा contractilize कर रहा है तो blood flow में variance आएगी, एक जैसा blood flow नहीं रहेगा. Increased blood flow in capillaries during exercise, during rest. Some muscle capillaries have little. Simple बात है यार, इसमें तो इसको पढ़ने की भी जरूरत नहीं है. पूरे पैराग्राफ को आपको इजीली समझ में आ रहा है कि if there are exercising muscles तो वहाँ blood flow ज़्यादा होगा towards the capillary. ठीक है? Now, control of the skeletal muscle blood flow, it's mainly the local metabolic needs. So, for example, if there is a muscle which starts exercising quite a lot, and because of that exercise होगा ये कि जो वहाँ ऑक्सीजन सप्लाई हो रही है वो कम हो जाएगी obviously, because अब एक्सरसाइज कर रहा है तो मसल को ऑक्सीजन चाहिए ज़्यादा. The large increase in muscle blood flow that occurs during the skeletal muscle activity is caused mainly by the chemicals released locally that act on the muscle arterioles and cause dilation. So largely it is the local control mechanism. One of the most important chemical which is very effective is the level of oxygen. If the level of oxygen goes down, the blood supply goes up because important vasodilator substances are released, such as adenosine, for example. Fortunately, even after the muscle blood vessels have become insensitive to vasodilatory effects of adenosine, other vasodilators are also working. So you need to know a few more vasodilators. यानी जब exercise हो रही होती है, so we have some vasodilators which increases the diameter of the supplying blood vessels, जिसकी वजह से blood flow ज़्यादा हो जाएगा. तो एक तो आपने याद रखना है adenosine, that's a very potent sort of vasodilator. Then potassium ions, ATP, lactic acid, beautiful, because exercising muscles में already lactic acid बन रहा होता है. Carbon dioxide, again beautiful, because exercising muscle में carbon dioxide बन रहा है. So ये वो चीज़ें हैं जो exercising muscle को ज़्यादा blood supply करने के लिए vasodilation का process करवाएंगे. And so this is the local control. So what we're talking about कि skeletal muscle का control system क्या है? So there is one local system कि muscle में से ये तमाम mediators produce होते हैं. So controlled vasodilation होती है. Then there are number 2 muscle blood flow के लिए nervous control. In addition to the local tissue mechanisms, skeletal muscles are also provided with sympathetic vasoconstrictor nerve endings, and in some of the animals sympathetic vasodilator nerve endings as well. The sympathetic vasoconstrictor nerve fibers secrete norepinephrine. When maximally activated, the mechanism can decrease the blood flow through the resting muscle to as little as 1/2 of the normal. So that's the power of the sympathetic nervous system. In addition to the norepinephrine secreted by the sympathetic nerve endings, the medullae of the 2 adrenal glands also increase large amount of norepinephrine. They can also exert effect on the muscle cells. The circulating norepinephrine acts on the muscle vessel to cause vasoconstriction as well. The epinephrine, however, has a slight vasodilatory effect too. So that's slightly confusing. कि ये epinephrine vasoconstriction भी करा रहा है, vasodilator भी करा रहा है, but इसको ऐसे ही आपको याद रखना है कि this is the way it is. The effect of sympathetic activation overall क्या होगा? At the onset of exercise, signals are transmitted not only from the brain to the muscle to cause muscle contraction, but also in the vasomotor center to initiate the sympathetic discharge in many tissues. Simultaneously, the parasympathetic signals to the heart are attenuated so that the blood supply is basically heartbeat बढ़ जाएगी, contractility बढ़ जाएगी, heart की cardiac output बढ़ जाएगा. तो ये है. Therefore, 3 major circulatory effects. Number 1, the heart is stimulated. ताकि सिंपैथेटिक सिस्टम की बात हो रही है, ताकि कॉन्ट्रैक्टिलिटी बढ़े और कार्डियक आउटपुट बढ़ जाए. Number 2, many of the arterioles of the peripheral circulation are strongly contracted, so the blood supply is more towards the muscles, which are strongly vasodilated by the local vasodilatory effect of the muscles. So इस वक्त चाहिए भी, ज़ाहिर हम अगर एक्सरसाइजिंग सिचुएशन में हैं तो मसल्स को ब्लड चाहिए, तो बाकी बॉडी का ब्लड सप्लाई शट किया जाता है, यहाँ का स्टार्ट किया जाता है. दैट्स कॉल्ड द लैंडिंग ऑफ ब्लड फिनोमिना, कि ब्लड का उधार लिया है, दैट सॉर्ट ऑफ थिंग. द मसल वॉल्स ऑफ द वेन्स एंड अदर कैपेसिटेंस vessels are contracted powerfully as well, which increases the mean systemic filling pressure. They also increase the venous return to the heart, and therefore the cardiac output increases as well. Okay. Now, the sympathetic stimulation may increase the arterial pressure during exercise. That's also a very important effect of sympathetic stimulation. An important effect of increased sympathetic stimulation in exercise is to also increase the arterial pressure. आपने देखा कि कार्डियक आउटपुट तो इंक्रीज हो रहा है बिकॉज ऑफ द डायरेक्ट सिंपैथेटिक स्टिमुलेशन ऑफ द हार्ट. द इंक्रीज आर्टीरियल प्रेशर किस वजह से होता है? नंबर 1, vasoconstriction of the arteriole, so that increases the pressure, and increased pumping activity of the heart, जो भी हमने डिस्कस किया भी था थोड़ी देर पहले, उसकी वजह से भी हार्ट चूंकि पंप ज्यादा करेगा, so there will be increase in blood pressure. a great increase in mean systemic filling pressure caused mainly by the venous contraction. So all those phenomena are actually working to increase the blood pressure in the arteries, obviously. These effects working together almost always increase the arterial pressure. This increase can be as little as 20 millimeters of mercury, but can go up to 80 to 100 even millimeters of mercury, depending on the conditions under which the exercise is performed. When a person performs exercise under tense conditions, but uses only a few muscles, the sympathetic response still occurs. In the few active muscles, vasodilation occurs, but elsewhere in the body, the effect is mainly vasoconstriction. So imagine how beautifully your system is actually controlled, कि अगर आप बैठ के बहुत हैवी बाइसेप्स के सेट्स लगा रहे हो, ये लड़के मेरी इस बात को समझेंगे कि मैं क्या कह रहा हूँ. सो अगर आप हैवी बाइसेप्स के सेट्स लगा रहे हो, बाइसेप्स बार बार कॉन्ट्रैक्ट कर रहा है, तो वहाँ चूंकि बाइसेप आपका हैवीली यूज हो रहा है, तो उसकी मेटाबॉलिक डिमांड ज़्यादा है. इस वजह से बाइसेप्स में वैसोडाइलेशन होगी और बाकी पूरी बॉडी में सिंपैथेटिक सिस्टम का इफेक्ट होगा वैसोकंस्ट्रिक्शन का. सो ब्यूटीफुल सिस्टम, इजंट इट? Now, conversely, if a person performs massively whole body exercise, such as running or swimming, the increase in the arterial pressure is often only 20 to 40 millimeters. This lack of large increase in pressure from the extreme vasodilation that occurs simultaneously. So basically, देखो ना, imagine करो एक condition कि if you are swimming, for example, if this is you swimming in the water, this is water. So if you, it looks like you are just lying there underwater and not swimming. But anyways, imagine this is you swimming. Then आपकी बॉडी के बहुत सारे मसल्स यूज हो रहे हैं. तो जब बहुत सारे मसल्स यूज होंगे, इवन अगर सिंपैथेटिक सिस्टम एक्टिवेट हुआ है जो वैसोकंस्ट्रिक्शन करने की कोशिश करेगा, लेकिन मसल्स चूंकि यूज हो रहे हैं, तो लोकल इफेक्ट क्या होगा मसल्स के कॉन्ट्रैक्ट होने का? दैट विल बी वैसोडाइलेशन, बिकॉज देयर विल बी लो ऑक्सीजन, देयर विल बी मोर कार्बन डाइऑक्साइड, इट नीड्स न्यूट्रिएंट्स, सो देयरफॉर देयर विल बी वैसोडाइलेशन. एंड द वैसोडाइलेशन actually overarches the vasoconstriction caused by sympathetic system. So why is increased arterial pressure during the exercise very important? So this is not happening without a reason. There is an important reason for this. When muscles are stimulated maximally in a laboratory experiment, but without allowing the arterial pressure to rise, muscle blood flow seldom rises more than about 8-fold. हालांकि जब ब्लड प्रेशर को उसमें चिप इन कर देते हैं, बढ़ा हुआ ब्लड प्रेशर, तो 20 लीटर तो ब्लड सप्लाई बढ़ जाती है towards the exercising muscle. So the point of whole this paragraph is the fact कि during exercise ये जो ब्लड प्रेशर बढ़ता है ये important है. उसका रीज़न ये है कि इस बढ़े हुए ब्लड प्रेशर की वजह से एक्सरसाइजिंग मसल तक ब्लड पहुंचता है, वरना उतना नहीं पहुंचेगा जितना उसको चाहिए. Now, importance of increased cardiac output. Obviously, यार cardiac output बढ़ेगा तभी तो ज़्यादा ब्लड जाएगा और जभी तो ज़्यादा ब्लड पहुंचेगा एक्सरसाइज में. The graphic analysis of changes in the cardiac output during heavy exercise. Let's have a look at figure 21 too, this one. और देखते हैं क्या बता रहा है. It shows a graphic analysis of large increase in cardiac output that occurs during heavy exercise. The cardiac output and venous return curves crossing at point A represent the normal circulation, and the curves crossing at point B represent heavy exercise. So if you look here, there are two crossovers. Point A, that's the normal intersection, and that's point B, that's the heavy exercise intersection of two different curves. और वो दो curves क्या क्या हैं ये हमने डिटेल में पढ़े हैं पिछली वीडियोस में कार्डियोवास्कुलर की. One of them is obviously the cardiac output curve, and the other one is showing you the venous return curve. Note that the great increase in the cardiac output requires significant changes in both the cardiac output curve and the venous return curve as follows. So basically what's happening here is that cardiac output is obviously going to a very higher point as compared to the normal resting situation, and this is required, by the way. You need this because cardiac output बढ़ेगा नहीं तो exercising muscle को blood पहुंचेगा कैसे, right? Now the increased level of the cardiac output, actually I would just skip this because this is not so important for you to remember. Now they study the venous return curve. We are not going to do that because I just told you we can skip this, okay? Now, in response to changes in both the venous return curve and the cardiac output curve, the new equilibrium point, which is point B, is achieved. And that is basically very important for exercising muscle. The overall fact is that there is increased cardiac output during exercise, as well as there is increased venous return. So the venous return is also increased, okay? Why? Because there is sympathetic stimulation and vasoconstriction of the blood vessels, veins, so more blood coming into the heart and more sort of blood coming to the heart means more blood also going out of the heart. So that is the story. हमने ये सारे concepts actually पिछली videos में discuss किए हुए हैं. So that's kind of just the repetition of the same thing. So you should be able to actually understand what I'm saying. If you don't, मेरा suggestion आपको ये है कि cardiovascular की सारी videos जा करके दोबारा से देखिए. Okay? Now let's talk about the coronary. So up till now we have been talking about basically the skeletal muscle blood supply of the skeletal muscles. Now we have to talk about heart muscles, or what happens in the coronary blood circulation. So let's start our discussion about coronary blood circulation. About 1/3 of all deaths in the industrialized countries of the Western world result from the coronary artery. That's why the coronary circulation becomes very, very relevant, because ischemic heart disease is a major killer and a major morbidity and mortality cause for many of the patients. For this reason, understanding the normal and pathological physiology of the coronary circulation becomes very important and highly relevant. Okay, now physiology तो हम पढ़ ही रहे हैं, बट यहाँ फिजियोलॉजी एनाटमी का डिस्कशन आ रहा है. सो एनाटमी एक्चुअली मैंने हार्ट की और कॉर्नरी ब्लड सप्लाई की बड़ी डिटेल में कराई हुई है, बट यहाँ क्विकली रिव्यू कर लेते हैं. फिगर 21.3 shows the heart and its coronary blood supply. Note that the main coronary arteries lie on the surface of the heart, and the smaller arteries then penetrate from the surface into the cardiac muscle tissue. So देखते हैं किधर diagram, this one. So that is showing you the heart and the coronary arteries, the right coronary and the left coronary. Anatomy में ये बहुत डिटेल में हमने डिस्कस किया हुआ है. Only the inner 1/10 millimeter of the endocardial surface can obtain significant nutrition directly from the blood inside the cardiac chamber. So this source of muscle nutrition is minuscule, 1/10 millimeter of the endocardial surface. So ये बड़ा important point है. देखो, मैं अपने बचपने में जब मैं खुद मेडिकल स्कूल में था, तब मैं ये सोचता था कि यार हार्ट के अंदर तो सारा खुद ब्लड भरा हुआ है ना, तो ये डायरेक्टली जो सेल्स हैं यहाँ पर उसको डिफ्यूजन के जरिए ऑक्सीजन क्यों नहीं मिल जाती. फिर समझ में आया कि भाई ये जो हार्ट की वॉल है ना, ये काफ़ी मोटी सी वॉल है, और इस वॉल का सिर्फ 1/10 millimeter ऑफ द एंटायर थिकनेस रिसीव करता है इस ब्लड से जो हार्ट के अंदर है उससे ऑक्सीजन. जिसका मतलब ये हुआ कि बाकी की पूरी वॉल को और बाकी के पूरे हार्ट को इट रिक्वायर्स proper blood supply. जैसे ये blood vessels हैं, these are therefore called the coronary blood vessel, and they're very important for supplying the heart. The left coronary supplies mainly the अच्छा, अभी ये segments याद रखना ज़रूरी है, because जो coronary block होगी उसके हिसाब से उस supply line का जो area होगा उस area में changes आएंगे. So अगर आप ECG भी देख रहे हैं तो for example अगर left coronary artery block हुई है thrombus की वजह से, तो anterior and left lateral portion of the left ventricle will be showing changes in the electrocardiography, whereas the right coronary supplies most of the right ventricle as well as the posterior part of the left ventricle. So that's very important to remember the supply areas of coronary arteries. Now most of the coronary venous blood flow from the left ventricle muscle enter to the right atrium of the heart by the coronary sinus. So जैसे हार्ट को आर्टेरियल ब्लड चाहिए, वैसे इसमें से वेनस ब्लड भी निकलता है. सो वो अल्टीमेटली जाता है कोरोनरी साइनस के जरिए इनटू द राइट एट्रियम, क्योंकि बाकी पूरी बॉडी का भी जो डीऑक्सीजनेटेड ब्लड है वो सब राइट एट्रियम में ही आता है ना, तो हार्ट में भी राइट एट्रियम में ही आता. ऑन द अदर हैंड मोस्ट ऑफ द कोरोनरी ब्लड फ्रॉम द राइट वेंट्रिकुलर मसल returns through small anterior cardiac veins that flow directly into the right atrium. तो यहाँ से भी यानी वेंट्रिकुलर राइट साइड से भी जो डीऑक्सीजनेटेड ब्लड है वो भी राइट एट्रियम में ही आ रहा है, बिकॉज पूरी बॉडी का भी प्रिंसिपल ये है कि सारी बॉडी का जो डीऑक्सीजनेटेड ब्लड होगा उसने अल्टीमेटली आना राइट एट्रियम ही में है. ओके, अ वेरी स्मॉल अमाउंट ऑफ कोरोनरी वेनस ब्लड also flows back into the heart through very minute Thebesian vessels which empty directly into all the chambers. So these are the ones जिनके लिए कोई बाउंड्री नहीं है, किसी भी चैम्बर में खुल जाती हैं, छोटी छोटी सी ब्लड वेसल्स हैं. Normal coronary blood flow averages 5% of the total cardiac output. So that's considerable actually. The normal coronary blood flow in the resting person is 70 ml per minute per 100 gram of the tissue, which is about 5% of the total cardiac output. Now during strenuous exercise, the heart in the young adult increases its cardiac output 4-fold to 7-fold, and it pumps this blood against higher than normal arterial pressure. Because अगर एक्सरसाइज करेगा तो उसके सिस्टम का आर्टेरियल प्रेशर भी बढ़ेगा और हार्ट को इस हाई आर्टेरियल प्रेशर के अंदर ब्लड डालना है, तो ऑब्वियसली हार्ट ज़्यादा काम करेगा. यंग बंदे में तो ये सेटिंग सही हो जाती है. Consequently, the work output of the heart under severe condition may increase 6 to 9-fold as well. At the same time, the coronary blood flow increases 3 to 4-fold to supply extra nutrients. So if the heart is pumping more because the person is exercising, तो हार्ट पंप भी ज़्यादा कर रहा है और खुद हार्ट को भी ब्लड ज़्यादा चाहिए, सो कोरोनरी सप्लाई भी बढ़ती है. Now this increase is not as much as the increase in the workload, which means that the ratio of the energy expenditure by the heart to coronary blood flow increases. Thus, the efficiency of the cardiac utilization of energy increases to make up for the relative deficiency of the coronary blood supply. So, बेसिकली बात यह है कि हार्ट फिर देखो हार्ट बहुत ज़्यादा तेज़ी से पंप करता है ताकि ज़्यादा से ज़्यादा ब्लड सप्लाई कर सके अगर डिमांड है, यानी कोई आप हैवी एक्सरसाइज कर रहे हैं तो हार्ट को भी ज़्यादा ब्लड चाहिए, लेकिन इतना ब्लड नहीं मिलता जितना ये काम करता है। बिल्कुल ऐसे ही कि जैसे आप अगर कहीं पे जॉब कर रहे हैं तो आपको अक्सर ये लगता है कि यार काम ज़्यादा कर रहा हूँ, सैलरी कम मिल रही है, उतनी सैलरी नहीं मिलती जितना मैं काम कर रहा हूँ। हार्ट का भी ऐसे ही है, हार्ट को उतना कॉरोनरी ब्लड इंक्रीज होकर नहीं मिलता जितना ये एक्सरसाइज में बेचारा खुद काम करता है। दैट्स द पॉइंट, ओके। Now, the cardiac muscle compression causes phasic changes in the coronary blood flow during systole and diastole. Now, फिगर 21.4 किधर है भाई? 21.4 दिखा दो यार, ग्राफ ही होगा कोई बड़ा अजीब सा समझाना पड़ेगा मुझे, स्टूडेंट्स बड़ा परेशान होते हैं यार ग्राफ से। सो दिस इज द डायग्राम दैट वी हैव टू लुक। सो दिस इज सिस्टली एंड दिस इज डायस्टली। सो व्हाट यू कैन एक्चुअली सी कि ये कार्डियक ब्लड फ्लो है ऑन द वाई एक्सिस। सिस्टली में कार्डियक ब्लड फ्लो कम हो रहा है और डायस्टली में कार्डियक ब्लड फ्लो बढ़ रहा है। ये क्या चक्कर है यार? चक्कर सिंपल है, चक्कर ये है कि ये आपका हार्ट है, इसकी वॉल में इमेजिन कि एक ब्लड वेसल है जो कि कॉर्नरी ब्लड वेसल है। जब हार्ट कॉन्ट्रैक्ट करेगा तो ये कॉर्नरी ब्लड वेसल बंद नहीं होगी, कॉन्ट्रैक्ट करेगा तो ये पिचक जाएगी ना। जब पिचक जाएगी तो ब्लड सप्लाई नहीं पहुंचेगा वॉल ऑफ हार्ट तक। तो बात यह है कि जब कॉन्ट्रैक्शन होती है सिस्टली तब ब्लड सप्लाई कम होती है बिकॉज कॉर्नरीज आर ब्लॉक्ड, और जब कॉन्ट्रैक्शन नहीं होती यानी रिलैक्सेशन होती है यानी डायस्टली होती है तो ये खुल जाती हैं और ब्लड सप्लाई मिलना दोबारा शुरू हो जाती है हार्ट को। सो दैट्स सॉर्ट ऑफ द स्टोरी दैट यू एक्चुअली हैव टू रिमेंबर। Okay, so during diastole, the cardiac muscle relaxes and no longer obstruct the blood flow through the coronary vessels, and therefore they supply the heart. Now, epicardial versus subendocardial coronary blood flow. देखते हैं इसका क्या मतलब है. Now, this is the figure that we will actually focus on. It demonstrates special arrangement of the coronary vessels at different depths of the heart muscle, showing the outer surface of the blood supply, which is called the epicardial blood. So this is the surface of the heart. So for example, if I am drawing a heart here, so what we are doing is looking at this in a very, very enlarged manner. So this is the heart surface, whole heart muscle layer. ये ऊपर की तरफ है तो ऊपर की तरफ जो वेसल है उसको हम नाम दे रहे हैं epicardial blood vessels. So these are called epicardial coronary arteries, which supply most of the muscle. Now, smaller intramuscular arteries derived from the epicardial arteries penetrate the muscle, supplying the needed nutrients also to the deeper layer. So you see this is all like dividing, and then there is a subendocardial arterial plexus as well. So it's like a ladder. Epicardial arteries are then connected with the endocardial arteries. Lying immediately beneath the endocardium is the subendocardial plexus. So that's the complete blood coverage of your heart tissue. Now during systole, the blood flow through the subendocardial plexus of the left ventricle, where the intramuscular coronary vessels are compressed greatly by ventricular muscle contraction, tend to be reduced. जब यहाँ contraction होगी तो obviously ये contract होंगी और systole में इसीलिए blood supply कम हो जाता है. However, extra vessels of the subendocardial plexus normally compensate for this reduction. Later in this chapter, we'll talk about this in more detail. तो ये तो था बेसिक बात कि कॉर्नरी सप्लाई है क्या, कौन सी आर्टरीज हैं, और अब मुझे बात करनी है कि हाउ दीज कॉर्नरी ब्लड वेसल्स आर बेसिकली कंट्रोल्ड। तो इनका कंट्रोल मैकेनिज्म क्या है। सो जैसे बाकी मसल्स में है, लोकल मसल मेटाबॉलिज्म इज द प्राइमरी कंट्रोल. So blood flow through the coronary system is regulated mostly by the local arterial vasodilation in response to the nutritional demands of the cardiac muscle. That is whenever the vigor of the cardiac contraction is increased. अगर आप exercise कर रहे हैं, अगर आप stress situation में हैं, the rate of the coronary vessel flow also increases. Conversely, decreased heart activity is accompanied by the decreased coronary blood flow. So heart अगर rest में है, कम demand है, कम blood जाएगा. ज़्यादा काम कर रहा है, ज़्यादा demand है, ज़्यादा blood जाएगा. This local regulation of coronary blood flow is similar to that which occur in many other tissues of the body. So this is same as we discussed for the skeletal muscle, as we discussed for anything else, okay? Now, oxygen demand is a major factor in local coronary blood flow regulation. Very important heading. Blood flow in the coronary arteries usually is regulated almost exactly in the proportion needed by the cardiac musculature. Kya cheez needed? Oxygen. Normally, about 70% of the oxygen in the coronary blood flow is removed as the blood flows through the heart muscle. Because not much oxygen is left there, little additional oxygen can be supplied to the heart musculature unless coronary blood flow increases. बात यह है कि जब एक्सरसाइज हो रही है, वैसे ही मतलब रेस्टिंग कंडीशन में ये हो रहा है कि 70% ऑक्सीजन इसमें से निकाल लेता है हमारा हार्ट. तो अब अगर हार्ट की कॉन्ट्रैक्शन बढ़ गई तो बाकी पीछे तो ऑक्सीजन इतनी बची नहीं है जो फर्दर एक्सट्रैक्ट करें, तो लाजमी आपको ब्लड सप्लाई बढ़ानी पड़ेगी ताकि एक्सरसाइजिंग मसल अपना काम कर सके. The exact means by which the increased oxygen consumption causes coronary dilation has not been determined. Now that's a very, very tricky area. Many researchers have speculated that a decrease in oxygen concentration in the heart causes vasodilator substances. This is the theory same as for the skeletal muscle, that we release a lot of vasodilators, and those vasodilators then, because the heart is working more, there are vasodilators and coronary blood vessels dilate. Adenosine is not the only vasodilator product that has been identified. There are so many others. Potassium, for example, hydrogen, carbon dioxide, prostaglandin, nitric oxide, they all have the tendency to dilate the blood vessels of the heart, yani ki coronary blood vessels. Now, the mechanisms of coronary vasodilation during increased cardiac activity have not been fully explained, but the theory is this, कि अगर heart contract ज़्यादा कर रहा है, तो वो ऑक्सीजन ज़्यादा यूज़ करेगा और vasodilator substances होंगे because of this hypoxia in the tissue, and then the blood vessels will be dilated. Okay. Now, pharmacologic agents that block or partially block the vasodilator substances effects of adenosine do not completely prevent the coronary vasodilation. इसका मतलब ये है कि ये सारे vasodilator थोड़ा थोड़ा अपना हिस्सा डाल रहे हैं. तो एक तो लोकल फ्लो है जो कंट्रोल करता है coronary supply को, दूसरा nervous system. Now, stimulation of the autonomic nervous system to the heart can affect coronary blood flow directly and indirectly as well. The direct effects result from action of the nervous transmitter substances such as acetylcholine from the vagus parasympathetic supply, as well as norepinephrine from the sympathetic nerves on the coronary vessels. So there are adrenergic receptors there as well. The indirect effects result from the secondary changes in the coronary blood flow caused by increase or decrease in the heart activity. So if the heart activity is increasing, coronary blood flow increases. The indirect effects, which are mostly opposite to the direct effects, play a far more important role than the direct effects. So these are pretty important. The sympathetic stimulation, which releases norepinephrine from all sympathetic nerves, and epinephrine as well as norepinephrine from the adrenal medulla, also increases, number one, the heart rate, and number two, the contractility. ये हमने कई दफा बात की है. It also increases the metabolism in the heart. In turn, the increased metabolism of the heart sets off local blood flow regulatory mechanisms for dilating the core. So whenever there is more metabolism, so the concept is this: if this is cardiac muscle and it is metabolically super active, so it is obviously producing a lot of waste products which needs to be washed out, और इसीलिए ज़्यादा blood supply चाहिए, vasodilation होगी. Okay. Now, then what we talk in contrast, if there is vagal stimulation, with its release of acetylcholine, it slows the heart, has a slightly depressive effect on the heart contractility as well, and these effect decreases the cardiac consumption because heart activity कम हो गई. So अगर आप इसको summarize करें, autonomic nervous supply को heart की तरफ जो आ रही है, उसमें if there is sympathetic nervous system activation there, then the heart is working more. Because it's working more, there will be vasodilation and increased blood supply. And the opposite is true if you are supplying, vagus, so acetylcholine, parasympathetic nervous system. Heart will not be pumping more. Reduction, in performance, reduced performance, slow heartbeat, less contractility. इस सब की वजह से heart की oxygen consumption नहीं, metabolically active नहीं है, so blood supply कम हो जाएगी, vasoconstriction. Okay. That sort of thing. So basically, जो parasympathetic supply है वो directly vasoconstriction नहीं कर रहा है इस scenario में, because heart की activity down हो रही है, उस वजह से vasoconstriction हो रही है. Alright. Now indirect effect है ये. So this is the indirect constriction. Remember. So indirect constriction because vagus ने heart की contractility को कम किया. अब चूंकि heart काम ही नहीं कर रहा तो वो कह रहा है यार मुझे नहीं चाहिए oxygen, constrict कर दो blood vessel. समझ रहे बात? So the direct effect of the nervous stimuli on the cardiac vasculature. Now, distribution of the vagus nerve fibers to the ventricular coronary system is not too much. It's not great coverage. However, acetylcholine released by the parasympathetic stimulation has a direct effect to dilate the coronary blood supply. देखो ये concept अच्छे से समझ लो यार. इसमें बहुत बच्चे कंफ्यूज होते हैं. मुझे कहते हैं यार एक तरफ आप ये बोल रहे हो कि अगर वेगल स्टिमुलेशन होगी तो ब्लड सप्लाई यानी कोरोनरी आर्टरीज कॉन्स्ट्रिक्ट होंगी. अभी मैंने ये बताया इनडायरेक्ट कॉन्स्ट्रिक्शन. उसकी थ्योरी ये थी कि जब वेगस सप्लाई हार्ट पे आएगा तो हार्ट का जो कॉन्ट्रैक्शन है वो रिड्यूस हो जाएगा. मैं बार बार बता रहा हूँ, जब वो रिड्यूस हो जाएगा तो मेटाबॉलिकली हार्ट डाउन हो गया ना, और जब वो मेटाबॉलिकली डाउन हो जाएगा तो ब्लड सप्लाई ज़्यादा तो नहीं चाहिए. अब ये कॉन्स्ट्रिक्ट हो जाएंगी ब्लड वेसल्स बाय प्रोडक्शन ऑफ द लोकल फैक्टर्स. सो डायरेक्टली वेगस इसको कॉन्स्ट्रिक्ट नहीं कर रहा. इनफैक्ट अगर वेगस का डायरेक्ट इफेक्ट आप देखें तो इट इज़ काइंड ऑफ वैसोडाइलेशन. सो इट डायलेट द कोरोनरी वेसल्स. Much more extensive sympathetic innervation of the coronary vessels occur. ये हमने पहले डिस्कस किया था. We see that the sympathetic transmitter substances, norepinephrine and epinephrine, can have vascular constriction or dilatory effects depending on the presence or absence of the constrictor or dilator receptors on the blood vessels. So the constrictor receptors are the alpha receptors and dilator receptors are beta. So अगर एक blood vessel ऐसी है जिस पे alpha receptor है तो यही sympathetic system है वो vasoconstriction करवाएगा. लेकिन अगर एक ऐसी blood vessel है जिस पर beta receptors हैं तो यही sympathetic nervous system dilation करवाएगा. Okay? Both alpha and beta receptors exist in the coronary vessels. In general, the epicardial coronary, so this is now not relevant. Metabolic factors, especially the myocardial oxygen consumption. बार यार, local consumption of oxygen, production of carbon dioxide. These are important local factors for controlling the blood supply. Also, the production of various vasodilators. Okay? Now, special features of cardiac muscle metabolism, the basic principles of cellular metabolism discussed in chapter number 68 through 73 apply to the cardiac muscle as like for other tissues. Okay, most importantly, under resting condition, the cardiac muscle normally consume more fatty acids than carbohydrates to supply the energy. 70% of the energy is derived from fatty acids. That's your heart, using fats. However, as is also true for other tissues, under anaerobic or ischemic condition, when the blood supply is reduced, cardiac metabolism must call on anaerobic glycolytic mechanisms for energy, therefore utilizing glucose. However, glycolysis consumes large quantities of blood glucose and at the same time forms large amount of lactic acid agar anaerobic respiration hogi. So that lactic acid will cause ischemic pain, the cardiac pain, the angina. As is true. So basically जब एंजाइना का पेन होता है तो कहानी ये हो रही होती है कि ये हार्ट है, ओवर डिमांड हुई, ज़्यादा काम कर रहा है, इसको ब्लड सप्लाई इतनी नहीं मिल रही, तो ये एनाएरोबिक ग्लाइकोलिसिस की तरफ चला जाता है. इट प्रोड्यूसेस लैक्टिक एसिड विच कॉजेस पेन. एज इज ट्रू, और ये बाकी मसल्स के लिए भी है. कभी जिम गए हैं, बहुत अरसे के बाद अगर जाएं तो थोड़ी देर के लिए दर्द होता है, कुछ दिनों के लिए दर्द होता है. क्यों? बिकॉज यू स्टार्ट प्रोड्यूसिंग एनाएरोबिक ग्लाइकोलिसिस प्रोडक्ट विच इज द लैक्टिक एसिड. इट accumulates in your muscles and causes pain. As is true in other tissues, more than 95% of the metabolic energy liberated from the food is used to form ATP in the mitochondria. This ATP in turn acts as the conveyor of energy for the cardiac muscle contraction and other cellular function. This is very important, currency of the cell. और पूरी body की currency है basically. In severe coronary ischemia, the ATP degrades first to adenosine diphosphate and then AMP. And then ultimately to adenosine. Because the cardiac muscle cell membrane is slightly permeable to adenosine, much of this agent can diffuse into the muscle or from the muscle out in the circulation. So therefore adenosine gets out, and that perhaps can be a marker of cardiac injury. The released adenosine is believed to be one of the substances that is a vasodilator substance of the coronary vessels. However, loss of adenosine also has a serious cellular consequence. Within at least as little as 30 minutes of severe coronary ischemia, as occurs after the myocardial infarct, about half of the adenine base can be lost from the affected cardiac muscle cells. So such an important line, you see. So ये cardiac cell से जब adenosine बाहर आ रहा है, so that can cause vasodilation to increase the blood supply. लेकिन जो loss of adenosine हो रहा है ना cell से, उसके consequences हैं. So within as little as 30 minutes of severe coronary ischemia, as occur with the myocardial infarct, about half of the adenine base can be lost from the affected cell. Furthermore, this loss can be replaced by new synthesis of adenine at a rate of about 2% per hour. Therefore, once a serious bout of coronary ischemia has persisted for 30 minutes or longer, relief of ischemia may be too late to prevent the injury and death of the cardiac cells, because you have already lost half of the adenine already. This is almost certainly one of the major causes of cardiac cellular death during myocardial ischemia. So everything is then related. There is less blood supply, so anaerobic glycolysis, the cell is now not in good condition, therefore degrading its ATP reserves, or then losing adenosine out of the cardiac cell. And this adenosine, which was obviously a very important metabolite in the cell, if it is lost to as much as 50% of the total value in the cell starts getting degraded. So इसीलिए हम कहते हैं कि MI मतलब myocardial infarction या ischemic heart disease में, IHD में, initial few minutes are very very important, because you can alter and reverse things there. Otherwise, once the permanent damage has happened, तो फिर करने के लिए ज़्यादा कुछ बचता नहीं है. Okay, so with this basic stuff, अगर मैं इसको summarize करूँ तो आपको ये मालूम है कि हार्ट की ब्लड सप्लाई है बाय द कॉरोनरी ब्लड वेसल्स, वो कंट्रोल कैसे होती हैं, लोकल मैकेनिज्म्स एंड ऑटोनॉमिक सिस्टम्स. ओके, नाउ लेट्स टॉक अबाउट सम पैथोलॉजिकल स्टफ व्हिच इज द इस्केमिक हार्ट डिजीज. द इस्केमिक हार्ट डिजीजेस आर अमंग्स द मेजर किलर्स in the Western world. About 35% of people in the United States who are over the age of 65 years or older, they die because of the ischemic heart disease. Okay, now some deaths also occur in younger people, but most of them are in the older age group. Okay, usually the death occur suddenly if there is ischemic heart disease, but sometimes the heart weakens और जो लेट कॉम्प्लिकेशंस हैं उनकी वजह से भी डेथ होती है. And what is the most common cause of ischemic heart disease? That's basically atherosclerosis. A frequent cause of diminished coronary blood supply is atherosclerosis, and it's a very simple concept to understand, because if this is your heart, for example, and there is a coronary blood vessel going towards the heart and supply the different regions of the heart, and if there is atherosclerosis within the coronary blood vessel, the blood supply to the heart will obviously be diminished, and that is the number one cause of ischemic heart diseases. Okay, now the atherosclerotic process is discussed somewhere else briefly in people who have a genetic predisposition to atherosclerosis, who are overweight or obese and have a sedentary lifestyle, so ज़्यादा घूमते फिरते नहीं है, चलते फिरते नहीं है, exercise नहीं करते, or who also have a high blood pressure. They are all at risk of developing endothelial injury, because जो coronary blood vessel की endothelium होगी, high blood pressure की वजह से भी damage होगी, अगर cholesterol levels body में ज़्यादा हैं, overweight हैं, तो ये these are all the predisposing factors. And as a result of this, what happens is large quantities of cholesterol gradually become deposited beneath the endothelium at many points in the arteries throughout the body, and coronary artery is no exception. इसमें भी जमा होना शुरू हो जाते हैं. Gradually, these areas of deposit are invaded by the fibrous tissue and frequently becomes calcified. And it is these areas जिसमें फिर sometimes it also activates platelets, and if platelets are activated, thrombus is formed and there is sudden blockage of blood supply to the heart. The net result is the development of the atherosclerotic plaque, which actually protrude into the lumen, and it kind of blocks the lumen. So if this is the lumen and this is the atherosclerotic plaque coming in, तो ये बाकायदा lumen के अंदर protrude करता है और जो blood supply है वो कम हो जाती है. And जैसे मैंने अभी बताया थोड़ी देर पहले कि अगर यहाँ activation हो जाए of the platelets, then the platelets will start forming a thrombus, and as a result there will be acute coronary artery occlusion. So acute occlusion occurs usually when the atherosclerotic plaque can cause local blood clot to form a thrombus which occludes the artery. The thrombus usually occur where the arteriosclerotic plaque has broken through the endothelium. So अगर यहाँ endothelial rupture होगा इस plaque की वजह से, then there will be thrombus, and if the thrombus detaches and start traveling, this can form the coronary embolus. Many clinicians believe that local muscular spasm of the coronary artery also occur. The spasm might result from the direct irritation of the smooth muscles of the arterial wall by the edges of the arteriosclerotic plaque. So also because of this, दो चीजें हो रही हैं. एक तो plaque की वजह से there is thrombus formation, and number two, it also causes muscular spasm of the artery. So spasm की वजह से भी there will be occlusion of the blood supply, and sometimes also damage to the endothelium and secondary thrombosis, because here the primary problem is spasm. Now life-saving value of collateral circulation, इस पूरे डिस्कशन का पॉइंट ये है कि हार्ट में there is a lot of collateral circulation. यानी एक blood vessel अगर थोड़ा सा compromised blood flow है तो दूसरी blood vessel can supply this, and that's actually life-saving. Heart जब ischemia develop करता है, so these collateral circulations, they start getting bigger in size actually. So when a sudden occlusion occurs in one of the larger coronary arteries, the smaller anastomosis begin to dilate within seconds. However, the blood flow through these minute collaterals is usually less than half of that needed to keep most of the cardiac tissue alive, because heart की अपनी requirement बहुत ज़्यादा है. So ये collateral circulation ऐसा नहीं है कि पूरी एक अगर artery block हो जाएगी तो collateral circulation take over करेगी. It's not like that. However, the blood flow through these minute collaterals usually less. ये point हो गया. The diameters of the collateral vessels do not enlarge much more than for the next 8 to 24 hours. Then, however, collateral flow begins to increase, doubling by the second or the third day, and often reaching the normal or almost normal coronary flow in about a month. So that's the beauty of the collateral circulation. But anyways, if the blood damage is too much, the blood vessel damage is too much, then the collateral circulation will obviously not be of great help. When atherosclerosis constrict the coronary arteries slowly over a period of many years rather than suddenly. Collateral vessels can develop at the same time, while the atherosclerosis become more and more severe, and in the background the collaterals are establishing. Therefore, the person may never experience acute episode, and suddenly he or she develops acute episode, and that becomes very, very fatal. So that can happen, obviously. Then myocardial infarction is the damage of the cardiac muscles because of the ischemia. So the area of the muscle that has zero flow or so little flow that it cannot actually sustain the cardiac muscle function, then that function is totally compromised, and the tissue is known to be infarcted tissue, and this is what we call in general terms as myocardial infarction. Soon after the onset of infarction, small amounts of collateral blood flow begins to infiltrate the infarcted area, but within few minutes, in a very, very short time, that part of the heart is dead if the circulation is not restored. Simultaneously, the muscle fibers use the last bits of oxygen in the blood, causing the hemoglobin to become totally deoxygenated. Therefore, the infarcted area takes a bluish-brown coloration. In later stages, the vessel's wall become highly permeable and leak the fluid. And within few hours, almost no blood supply, agar nahi hai bilkul bhi, then the cardiac cells will die. Or cardiac cells की actually requirement है about 1.3 ml of oxygen per 100 gram of muscle tissue per minute just to remain alive. In comparison, about 8 ml of oxygen per 100 gram are delivered to the normal resting reference. So requirement है 1.3 की, और usually resting condition में भी deliver किया जाता है 8 ml, यानी ज़रूरत से बहुत ज़्यादा deliver किया जाता है oxygen heart को. Therefore, if it is even 15 to 30% of the normal, यानी अब नॉर्मल से कम हो जाए इतना 1.3 तक भी कम, 1.3 तो नॉर्मली कंजम्पशन है, तो काफ़ी हमारे पास गुंजाइश है ऑक्सीजन सप्लाई को कम करने की. नेचर ने डिज़ाइन ऐसा रखा है कि अगर फेलिंग हार्ट भी हो और हार्ट में इस्कीमिया भी हो, तो इट एक्चुअली नीड्स द ऑक्सीजन लेवल्स टू गो वेरी, वेरी डाउन बिफोर द हार्ट कैन एक्चुअली एक्सपायर. एंड बिकॉज ऑफ द एनाटॉमिकल डिस्कशंस जो भी हमने पहले भी डिस्कस किए, जो सब एंडोकार्डियल एरिया है यानी एपिथेलियम के नीचे का एरिया, दैट इज मोस्ट प्रोन टू infarction. So subendocardial infarctions are very, very common. This is the area earliest to infarct usually. Now, causes of death after acute coronary occlusion. The most common cause of death after acute myocardial infarction are the following. Number one is the decreased cardiac output. Obviously, if the heart is now not receiving the blood, this part of the heart is dead, and if it is not pumping properly, there is no blood coming out of the heart properly. So this is what we call decreased cardiac output. Different parts of the body will not receive appropriate amount of oxygen. So this is one problem, decreased cardiac output. The other problem can be damming of the blood in the pulmonary vessel. So because heart is not pumping in the left ventricle and atria, in the left atria, blood from the lungs are coming back via the pulmonary veins. So if it is not pumping, there will be no pumping of this blood outside the heart. Therefore, the left atrium will not be empty, and there will not be emptying of the pulmonary vessels. So there will be pooling of the blood in the pulmonary vessels. Once they pool in here, as a result of this, it will also go, and have pressures in the lungs, or lungs में भी fluid की leakage होगी, which is what will lead to pulmonary edema. So there is decreased cardiac output, there is damming of the blood in the pulmonary vessel, there is pulmonary edema, there can be sudden fibrillation of the heart, atrial or ventricular fibrillation because of blood is stagnant there, and occasionally there can be rupture of the heart as well. Okay, बाकी ये details अब इन्हीं सारे concepts की है. So decreased cardiac output we know because heart is not working properly. Then damming of the blood in the body's venous system because heart से forward blood नहीं जा रहा, so push होके बाहर नहीं निकल रहा ventricle से, इसलिए पीछे जो veins empty हो रही हैं, they are pooling blood. There can be fibrillation, ventricle fibrillation, because there is blood actually stagnant in the ventricles. And let's try to discuss this a little bit more. In many people who die of coronary occlusion, death occurs because of sudden ventricular fibrillation. The tendency for fibrillation to develop is especially great after a large infarction, but fibrillation can sometimes also occur even after smaller infarctions. Some patients with chronic coronary insufficiency die suddenly of fibrillation without even having an acute myocardial infarction, क्योंकि over the period of time they develop collateral circulations. तो उनका कोई acute event नहीं होता, but suddenly they develop fibrillation. Fibrillation is most likely to occur during two especially dangerous periods after coronary infarction. The first period is during the first 10 minutes. So this is the critical time after the infarction. So अगर किसी को heart attack हुआ है, myocardial infarction, the first 10 minutes are really critical because इसमें the banda can develop fibrillation. Then there is a short period of relative safety, followed by a second period of cardiac irritability beginning 1 hour or so later, lasting for another few hours. So these are the time periods that you need to remember. कि कौन-कौन से एरियाज हैं टाइम वाइज जिसमें fibrillation हो सकता है, arrhythmias हो सकते हैं. At least 4 factors are involved. Number 1, acute loss of blood supply to the cardiac muscle. Obviously, coronary blood supply disturbed hai, so there is less blood supply, and this causes rapid depletion of potassium from the ischemic musculature. This also increases the potassium concentration in the ECF. Experiments in which potassium has been injected into the coronary system demonstrated that an elevated extracellular potassium concentration increases the irritability of the cardiac musculature, and therefore it is likelihood of fibrillating. So is the potassium change dynamics because of loss of blood supply. The second factor can be ischemia of the muscle, causes an injury current, and this injury current can lead to sudden depolarization current throughout the ventricle. Powerful sympathetic reflexes often develop after massive infarction because the heart is not pumping, the body is not getting blood. The sympathetic system is activated, and part of the systematic problems which are associated with myocardial infarction is that the sympathetic system is overactivated, and it tries to come onto the heart, tries to overactivate it in an attempt to restart the heart ताकि cardiac output दोबारा से बढ़े. Sometimes the sympathetic system simply misfires and a new rhythm is set, which is what we call the fibrillation. And the fourth factor is muscle weakness causes myocardial infarction. इसकी वजह से जो muscle weakness हो रही है, it sometimes causes ventricles to dilate excessively because now muscles are very weak, they cannot contract properly. So there is a dilated type of focal dilated cardiomyopathy. This excessive dilation increases the pathway length for the impulse. So if this is the heart which is normal and now this is the heart which is abnormal, so there is certain dilation after myocardial infarction. So the pathway for the fibers through which the depolarization wave has to be conducted वो बढ़ गया, और उसके बढ़ने की वजह से there can be current abnormalities. Circus movements ये हमने पढ़ा भी जब cardiac physiology हम earlier on कर रहे थे, पिछली मेरी किसी वीडियो में है ये concept. So आपसे कोई अगर ये सवाल करता है कि MI के बाद fibrillation या हार्ट के रिदम में जो चेंजेस आते हैं उनके फैक्टर्स क्या क्या हैं? So 4 factors: loss of blood and injury current, powerful sympathetic reflex, and also the dilation of some part of the heart. Now, rupture of an infarcted area is also very, very notable phenomena, because what happens that if this is your normal heart and this is the area where there was infarction, so if the patient survives after infarction, this area is no more the normal area, and it has the potential to become weak. And after the patient has survived, what can happen is this part has now potential to be dilated while the rest of the heart is contracting. So during systole, when the systolic movements are happening, heart jab contract kar raha hai, so all the muscles which are normal, they will contract, but this part which has become weak now, it will actually dilate, and this dilated part of the heart has then the potential of getting ruptured, and this is a pretty common complication of myocardial infarction. So during the first day or so after an acute infarct, there is little danger of rupture of the ischemic portion of the heart, but it actually happens after a few days later, when the muscle tissue is now very weak and there is some fibrous tissue, it has now potential to be ruptured. When this happens, the dead muscle bulges outwards, जो अभी मैं आपको concept समझा रहा था. One of the methods used to assess the progress of severe myocardial infarction is to record the cardiac imaging by using MRI or CT scan to identify if there is a chances of ballooning out of some part of the heart during contraction. When a ventricle does rupture, loss of blood into the pericardial space happens, and the heart is then surrounded by blood. And this complicates the problem because now the heart cannot contract properly, and this is what we call cardiac tamponade. Cardiac tamponade means that there is blood in the pericardial cavity, and ये compress करेगा पूरे cardiac structure को, so that the heart cannot perform its contraction and relaxation normally. Now, stages of recovery from acute myocardial infarction. The figure 21.8, which we will have a look at in a moment, shows the effect of acute coronary occlusion in a patient with a small area of muscle ischemia. To the right is shown the heart with a large area of ischemia. When the area of ischemia is very, very small, no death of the muscle or very little death of the muscle tissue actually happen. But if larger area is ischemic, then there is obviously large part of the heart getting dead. So if you look at this diagram, for example, so this is mild ischemia and this is mild ischemia, but then if the ischemia is massive, there will be massive destruction of the cardiac tissue. So because of this ischemia, this part becomes non-functional, okay, and some of the fibers in the center are actually getting died, right? Now when the area of ischemia is large, some of the muscle fibers in the center die rapidly. जैसे कि इस diagram में दिखा है कि in the center they are getting dead, okay. Right, immediately around the dead area is a non-functional area, which still is not dead, but it has now become non-functional. It cannot contract. If the initial insult is gone and the blood supply is restored, then it can also start re-functioning. Then the extending circumferential level, this is irrelevant. Now replacement of the dead muscle by the scar tissue. Now this is a general phenomenon in the body. Wherever in the body there is ischemia, necrosis, then the outcomes can be fibrous scar formation. If this happens in heart, it's not a good news, because now again, when the rest of the heart is contracting, the scar tissue will actually be bulging out, okay. Now value of rest in treating MI. The degree of cardiac cellular death is determined by the degree of ischemia and workload on the heart muscle. When the workload is greatly increased, such as during the exercise, in severe emotional strain, or as a result of fatigue, the heart needs increased oxygen supplies. So obviously it's a good idea to ask the cardiac patient to under resting conditions, so to rest more, because heart already under stress hai. Furthermore, anastomeric blood vessel supplied to the ischemic area also increases. When the heart becomes excessively active, the vessels of the normal musculature become greatly dilated. This dilation allows most of the blood flow of the coronary vessels to flow through the normal muscle, thus leaving the little blood to flow through the infarcted muscle. As a result, the ischemic condition worsen, So the bottom line story is that this patient should be resting. Otherwise, if the person is working, so think about it like a vicious circle. अगर किसी को myocardial infarction है, so and the person is exercising still, तो cardiac output बढ़ाने के लिए obviously cardiac load बढ़ रहा है and the cardiac functioning is increasing. So because the cardiac functioning is increasing and this is the area which is already dead, what will happen is there will be collateral blood supply, which will actually supply blood to the normal parts of the heart and not to the dead part. तो ये situation मज़ीद worsen होगी. We need to rest, the patient should be advised to rest. Otherwise it will be the coronary steal syndrome. So this is the area जहाँ blood supply पहुँचानी है, oxygen पहुँचानी है, but still बाकी areas को पहुँच रही है blood supply, इस area को नहीं पहुँच रही. So that's not a good thing. Now, heart functions after recovery from MI. Occasionally a heart that has recovered from large MI returns almost to full function. This also happens sometimes, not all the patients with MI immediately die. This does not mean that the person is necessarily a cardiac invalid or that the resting cardiac output is depressed below normal, because the normal heart is capable of pumping 300 to 400% more blood per minute than actually it is required by the body. So it is actually, understandable that even after MI, the heart can function to meet the body blood requirements. Now, obviously in the coronary heart disease, there is an element of pain, which is what we call angina pectoris, also called the cardiac pain. Normally a person cannot feel the heart because we just cannot feel the stretch mechanisms. Exactly what causes this pain is not truly understood. It's not fully understood. But it is believed that ischemia causes the muscles to release acidic substances such as lactic acid. And this lactic acid is the cause of this angina pectoris. In most people who sustain progressive constriction of their coronary vessels, they feel this pain, particularly when they are exercising. But this pain is sometimes absolutely absent in patients who are diabetics. So in diabetics, we have chances to see a painless heart attack, which means they will have the MI, but their pain will not be felt by them. को पता ही नहीं चलेगा कि कब अटैक हुआ कब गया. That sort of story. Okay. Treatment of ischemic heart disease and MI, that's a whole different topic that we study in medicine. But for now, just try to understand that we try to, the treatment is actually aimed to restore the blood supply. So if possible, the coronary blood vessel thrombus, it should be broken, it should be mobilized, the blood supply should be restored. But it is not as simple as that. You have to gauge the patient. that कितना time हो गया है MI को generate हुए, and we do that by doing some laboratory investigations. So that needs to be taken care of first, and then you decide the management plan. But anyways, that sort of management you do. You try to break the thrombus, you try to give nitroglycerin, which is a vasodilator. You try to give so many other drugs such as angiotensin receptor blockers, calcium channel blockers, ACE inhibitors. They may be particularly of use in patients with angina, so coronary blood vessel occlusion, and those having these symptoms can be controlled. Another class of drugs that are used for prolonged treatment of angina are the beta blockers, and they are known to reduce the mortality in these patients. But by no means this paragraph is sufficient to understand the management of myocardial infarction or ischemic heart disease. It's a designated big topic in the medical textbook, and we'll deal with this when we study medicine. And then there are some surgical corrections such as bypass surgery. Heart का बड़ा common हम सुनते हैं. Aortic coronary bypass surgery. In many patients with coronary ischemia, the constricted areas of coronary arteries are located only a few discrete points blocked by the atherosclerotic disease, and the coronary vessels elsewhere are normal. So earlier in 1960s, a surgical procedure called the cabbage, जिसको हम कहते हैं aortic coronary bypass or coronary artery bypass grafting, cabbage. It was developed in which a section of the subcutaneous vein is removed from an arm or the leg and then grafted from the root of the aorta to the side of the peripheral coronary beyond the atherosclerotic blockage point. So the whole idea is that if this is your heart and this is a blood supply going to the heart, and this is what we call the coronary blood vessel, suppose it is blocked here. So what you basically do is कि इसी बंदे के leg से कोई long vein such as saphenous उसका एक piece लेके, and then you graft that piece of the vein distal or parallel to the blockage and then connect it with the aorta. So from the aorta directly oxygenated blood is going in here and being supplied to the heart. So basically ये जो blockage था उसको bypass कर दिया. So that is what is known as the bypass surgery. That's the whole concept. Okay. Now coronary angioplasty is another technique developed a little later in 1980s, a procedure that has been used to open partially blocked coronary vessels. And this procedure is itself called coronary artery angioplasty. So there are so many balloon angioplasty, for example. So if the blood vessel is occluded by, say for example, an atherosclerotic plaque, we can insert balloons which can dilate the blood vessel lumen actually, and that is what we call angioplasty. Okay, a small balloon is tipped with a catheter. It gets inside and kind of restores the blood supply. And there are so many advanced techniques. Sometimes you also place stent. So the problem here, for example, is that the atherosclerotic plaque is, narrowing the lumen. And what we can do is dilate it by the balloon and then put a metal stent actually, so that this plaque does not again block the blood vessel. तो दोबारा blood vessel block नहीं होगी, और चूंकि ये metal stent है तो आपने एक छोटा canal बना दिया है जिसमें से blood गुजरता रहेगा. So we can also use stents like this. So these are some important considerations, and there are so many newer procedures which we are not going to discuss in this chapter, by the way. So that's all about chapter number 21. Pretty important chapter, and blood supply is the main game to the heart. If blood supply is disturbed, the story is disturbed. Okay, so I hope you liked the video. If you did, please share it with colleagues and subscribe the channel. यार आपसे मिलते हैं फिर अगली वीडियो में. बहुत जल्द अपना ख्याल रखिएगा.